Good afternoon. I'm here with Associate Professor Marcus Skinner from Tasmania, who's just given us a stimulating and provocative talk on safety in endoscopy anaesthesia. Marcus is a practicing anaesthetist at the Royal Hobart Hospital, and he's a former RAAF officer. He's previously been the Director of Anaesthesia and Perioperative Services at the Royal Hobart Hospital, and now he's the Director of Surgical Services and Perioperative Medicine for the state. He's been awarded the Order of Australia in 2018 and currently holds a private pilot's licence, which I've been told he has aerobatic endorsement, and I'm not going to ask any more about that because we've spoken enough about risk today. So thanks for joining us, Marcus.
Thanks, Jack.
Appreciate that.
Thank you.
Fantastic talk. Can I first ask you what stimulated your interest in safety in endoscopy?
Look, Jack, I think it's interesting, isn't it? All of us, if you've done enough endoscopies, we've all had our issues with it. And I think the reality is I had a few events in the mid-2000s where, although no bad outcome for the patient, I know that it was pretty untidy and we could have done it better. And I sat back one afternoon specifically after doing an ERCP and thought, gee, we've got to have a better way of doing this.
Absolutely, I concur with that, I think. What were your key points about safety and perhaps our apparent misconceptions about safety?
Yeah, look, it's very interesting. The more we look at how we actually perform outside the operating theatre, all of the evidence tells us that in fact the risk issues related to anaesthesia outside of the operating theatre is higher. Now, that's true for endoscopy, and if we look at that even more closely, the issues become even more confused when we look at outpatient diagnostic endoscopy versus inpatient therapeutic endoscopy. And there is a spectrum there, and unfortunately many of the papers that have told us that endoscopy is extremely safe are related to the former rather than the latter.
Okay. Has it changed what you tell your patients, what you've found out?
Yes, it has. Yeah. I'm very upfront and clear with my patients. Yeah. The young, fit, healthy person who's coming in for a diagnostic endoscopy, of course, most forms of sedation or deep sedation or indeed general anaesthesia, that patient is going to go home without an issue. And that is the perception that it is extremely safe. The data tells us another component, and that other component is, in fact, it's not as safe as we believe. And when you look at that data, there are specific issues that stand out, and those specific issues relate to the therapeutic, longer procedures and whether or not you are in fact having them done in an outpatient setting or indeed within a tertiary facility with multiple comorbidities.
Sure. A couple of things that were mentioned during the talk were the potential changes we might see in endoscopy going forward. Can you elaborate on what to expect in the future?
So look, there are many papers now suggesting that what we need to do is we need to assess patients more clearly, identify those patients that are coming to us for endoscopy, and there are multiple studies, but essentially about 1 in 10 patients we need to have our yellow flags go up and say this patient is a patient who meets the criteria that are going to provide us with some problems, and we need to manage those patients with all of the due diligence that we have in relation to what we would do to that patient in the OR.
Sure, okay. Are there any specific things that you would say to an anaesthetic registrar now, based on what you've researched, about how to try and close that practice gap that you've identified?
Look, I think it's culture and practice both in Australia and overseas. You know, our junior registrars have to get training, they have to get exposure and get experience, and we send them off to our endoscopy lists. The evidence would support a process that our junior registrars doing those lists probably need a higher level of supervision.
Sure.
In that environment.
Okay. Now this afternoon you're delivering a talk on a completely different topic. Can you elaborate about that and indicate why some people should attend that? Okay.
Look, I was very fortunate in my previous life. I was a military medical officer. I have considerable experience in aviation and aeromedical retrieval processes and did many deployments whilst I was within the military, and indeed after anaesthesia training on the Air Force Reserve. I was asked by the Australian Antarctic Division Polar Medicine Unit to assist initially in a retrieval from McMurdo in Antarctica, and when we realised what the nature of this event was, We absolutely said yes. The Royal Hobart Hospital supports the Australian Antarctic Division, trains up their staff, and we provide specialist support to the AAD. So when we were asked to undertake this retrieval, of course with excitement we said yes, we can provide that. It raises a whole number of logistic issues retrieving a patient from Antarctica. I've now done 2 major cases to Antarctica and have had 3 trips to the ice. The logistics required to remove a patient out of Antarctica are broad, and I'm looking forward to discussing that this afternoon.
Sounds like a fantastic talk. I've seen you speak about it before, so it should be a brilliant afternoon. Have you had any other highlights of the ASM so far? Any other speakers that you've enjoyed hearing?
Jack, I think this has been a fantastic ASM. I'm very proud as a Tasmanian, very proud of our colleagues who have put this conference together. As you know, we can't host such numbers in Tasmania, and to do it here in a foreign country, Kuala Lumpur, as a big city, it's fantastic. I also attended the SIG airway meeting at the weekend, and that was also another fantastic meeting. It's just wonderful to be able to meet with colleagues and be excited by the practice-changing evidence that they're providing us.
Absolutely. Well, from one proud Tasmanian to another, thanks for joining us.
Thanks very much, Shane. Well done.